This is the last part of hematology topics in SEM1. We will discuss the rest of the laboratory assessment, which will include bone marrow aspirate examination and RBC and WBC counts. For the bone marrow aspirate examination, we have to know what are the best sites to collect the specimen. For example, in adults, ang mnemonics natin is RSVP. R is ribs, S, sternum, shoulder blades or skull. In lesser, in lesser usage tong mga to kasi very tricky, very risky due to distance from the organs. And then V, vertebra, P, pelvis, and proximal ends of long bones. Halimbawa, yung tibia ng legs. And then, what are the preferred site of collection? Sa adult, most commonly used is yung pelvis, lalo na yung anterior and posterior iliac crest of the pelvis. And kapag naman bata, no, medyo maliit tong part na to. So, hahanap ka ng mas malaki pang bone. And pag bata, ang preferred site is the long bones, especially yung tibia, the anterior medial side of the tibia. And itong bone marrow aspirate should be kept for 10 years. Back in your histopath, di ba? Kasama siya sa mga specimen na dapat itago for 10 years for legal matters. Okay, how to assess a bone marrow aspirate? So, number 1, we will determine the level of microcellularity. Anong ibig sabihin ito? We will compute the levels of marrow cells, no, yung ating hematopoietic cells as compared to the fat cells. Okay? Meron tayong rule of the thumb na kapag adults, mas maraming fat cells. Kapag newborns, mas marami naman ang hematopoietic cells or marrow cells. Okay, normally, no, we can appreciate a ratio of 30 to 70%. Below 30, yun na tinatawag natin hypocellular. Above 70, hypercellular. Okay? And then, meron din tayong result na tinatawag natin aplastic. Ibig sabihin, wala ka halos nakikitang hematopoietic cells, no? Almost fatty yung nakuha mong bone marrow aspirate. And then, you will also observe for the normality of the presence of the cells. Kailangan ito lang ang makikita mo sa bone marrow aspirate mo. Number 1, yung mga immature stages or hematopoietic cells. No? Number 2, macrophages. 3, mast cell. And then lastly, dahil nga bone pa rin yung pelvis, may ma-appreciate kang bone cells such as osteoblasts and osteoclasts. Okay? Other than this, baka meron tayong problema, no? Baka meron tayong mga cancer cells, no? Fibroblasts in cases of myelofibrosis, yung mga ganyan. Those are abnormal marrow cells. And then after observation of the cellularity, mag-count ka na, no? You have to prepare 2 slides for the differential count. How to do the differential count? So first, you will count 500 cells per slide. So kapag dalawang slide, 500 times 2, so 1,000 yan. Okay? And you have to expect, no, myeloid erythroid ratio of 2:1 or 4:1. Bakit mas marami ang myeloid? Myeloid will form your WBC lineage. Your erythroid will form the RBC lineage. Diba, ang WBC lineage natin, maraming yan. From your neutrophil, agranulocytes to granulocytes, diba? May 5 tayong family of WBC. Kaya mas marami dapat ang myeloid cells as compared to your erythroid cells. Okay? In terms of leukemic patients, sumusobra yung myeloid cells as compared to your erythroid cells. Umaabot ng more than 10:1 ratio. Okay? Example, mag-compute tayo. Okay? So, ang nabilang mo sa slides mo ay 120 myeloid cells and 40 erythroid cells. So, paano ka magko-compute ng ratio? You divide 120 by 40. So, may kuha mo is 3. And ilalagay mo yung answer mo dun sa mas malaki ang number. For this example, mas malaki ang number ng myeloid. So, dito mo ilalagay yung answer mo. So, 3:1. Okay, another example, dito tayo. Myeloid cells ng 30, erythroid cells ng 150. So, divide mo yung larger number by the smaller number. 150 divided by 30 is 5. Ilagay mo to sa mas malaki yung cell part. So, sa erythroid cells, mas malaki. So, 1:5 ratio ang ME ratio natin. Let's proceed with the principles of hemocytometry. Unahin natin yung mga types of counting chambers. So, mga counting chambers can be classified according to the type of rulings, no? Yung paano nila dinivide yung kanilang mga squares. So, unahin natin yung most commonly used, yung improved na Neubauer. It has 2 sections, 9 square millimeter per area. Ang depth niya is 0.1 millimeter and ang square ay 9. So, kailangan itong information nito to compute for the total volume per section. So, one section, imumultiply natin yung area times the depth. Okay? So, 9 cubic millimeter. So, since dalawa, magiging 1.8 cubic millimeter. Okay? Iwanan na natin to. Doon tayo sa next. Sa Fuchs Rosenthal counting chamber. Pareha sila. Dalawa ang sections. Area, 16 square millimeter. With depth of 0.2 millimeter and with 16 squares. Okay? Paano mag-compute ng volume per section? Multiply ang area and depth. So, 16 times 0.2, 3.2 cubic millimeter. Dalawa ang sections. So, 6.4 cubic millimeter. Dito naman tayo with Spears-Levy. Okay. 4 naman ang sections ng Spears-Levy. Area is 10 square millimeter. Depth is 0.2 millimeter. Ang squares, pareha sila ni Fuchs Rosenthal na 16. To compute for the volume, area times depth dapat yan. 10 times 0.2 is 2 cubic millimeter. So, 4 yung section. So, 8 cubic millimeter all in all. Recall natin yung ating mga counting chambers. So, improved Neubauer itong una. Okay? Ilan ang sections ng improved Neubauer? 2. Ilan ang area natin? 9 square millimeters. The depth is 0.1 millimeter. And ilan ang squares? 9 squares sila. Okay? And then, sa Fuchs Rosenthal naman, we have 2 sections as well. The area is 16 square millimeter. The depth is 0.2 millimeter. And ilan ang squares daw sa Fuchs Rosenthal? 16. Okay? Dito naman tayo sa Spears-Levy. Ilan daw ang sections ng Spears-Levy? Diba? 4. And then the area is 10 square millimeter. The depth is 0.2 millimeter. And the total number of squares ay 16. Okay, focus tayo with the improve Neubauer counting chamber. So, pag ginagamit ito, anong mga area ang ginagamit for WBC count and RBC count? Ang WBC count uses the 4 large corner squares, while the RBC count uses the central square, pero 5 small square lang ng central square. Okay? And then for this part, i-differentiate natin the techniques on how to count the RBC and WBC using the Neubauer counting chamber. So, in terms of diluting fluid, different type dapat ang para sa WBC and RBC. Sa RBC, dapat isotonic fluid to preserve the RBC membrane. Okay? Sa WBC count, hypotonic fluid dapat. In hypotonic fluid, it can burst all the cells except your WBC and NRBCs. No? And some of the hypotonic cells, hypotonic diluting fluid can stain well the WBC nucleus. Therefore, mas easy mo silang ma-identify under microscope. An example of isotonic diluting fluid is your NSS, which is the most common na ginagamit. Pero the best or the most preferred diluting fluid for RBC count is DACs or formol citrate. While sa ating WBC count, most common is acetic acid, but the most preferred is the Turk solution. In terms of dilution factor naman, remember, mas malaki ang dilution factor ng RBC count dahil mas marami sila as compared to your WBC. So, 1:200 RBC, WBC is 1:20. Sa pipetting, pipetting manner, dalawa ang pwede mong gamitin, no? RBC Toma pipette and the WBC Toma pipette. So, ano ang difference ng dalawang material? The RBC Toma pipette has the red bead. So, ito yung marking mo, no? Ito ang gagamitin mo for your RBC. And it has a 101 mark to achieve the 1:200 dilution factor. Okay? While in WBC count, ang Toma pipette ay may white bead and has 11 marks. So, papakita naman natin yan later on. And again, recall natin nga, ang RBC count uses the 5 small squares in the central large square and the WBC count uses the 4 corner large squares. So, ito ang difference ulit ng mga Toma pipettes natin, no? Unahin natin yung red blood cell Toma pipette, which has red bead and 101 mark. And it may contain 100 units of blood and the diluting fluid inside the bulb. Okay? Bakit 101 and then 102? Ba't hindi pantay? Dahil yung 1 unit is nasa ibaba. Okay? And then, while dun sa ating WBC Toma pipette, it has a white bead, 11 mark, and it may contain 10 units of your blood and diluting fluid in the bulb. Okay, in this part, no, we will present the formula to compute for your RBC and WBC. Pero kailangan natin kuhain muna yung ating mga data. So, unang data na kailangan natin is the dilution factor. So, sa RBC count, mas mataas, 200. WBC count is 20. And then, for the area correction factor, ilang squares, no? Mini squares ang gagamitin para bilangin yung mga counts natin. Remember sa RBC, no? 5 yung gagamitin natin small square. Okay? So, WBC count, 1/4. Okay? Ang explanation dito is that hindi nga pantay yung area, kaya natin tinawag na ACF, no, area correction factor, to adjust for the area of the square. Okay? Ay, 4 yung square na ginamit natin. So, 1/4 ang or 0.25 ang ACF natin for WBC. Sa depth factor naman, parehas sila, no? Since the same ang depth ng all throughout the Neubauer counting chamber, which is 10. So, i-compute natin. Paano i-compute? I-multiply lang natin yung tatlong information. Pero, since para mas mapadali ang buhay natin, gamitin na lang natin yung shortcut. Kapag RBC count, i-multiply natin yung nabilang natin ng 10,000. Sa WBC count, i-multiply lang natin by 50. Okay? So, in long cut natin, supposedly, no, number of cells, multiply by the dilution factor, multiply by ACF, multiply by depth factor. Okay? Itong tatlong information ang kailangan natin for the formula. Then, pag minultiply mo lahat, gamitin natin yung shortcut. No? Number of cells times 10,000 for RBC, multiply by 50 kapag WBC. Okay, reference ranges naman tayo. So, magkakaiba yan, no? Per unit used and kung ilang taon na yung ating patient. Okay? Pag units, no? Ang traditional unit is dapat in RBC ha, 10 raised to the 6th power per microliter or cubic millimeter. Pagdating kay SI unit, 10 raised to the 12th power over per liter of blood. So, ang conversion factor natin is always 10, multiply natin by 10 raised to the 6. Okay? So, kapag multiply tayo, di ba, kapag exponents, laging addition yan. No? So, 6 plus 6, 12. Susubukan natin sa WBC. Ang traditional unit is 10 raised to the 10 raised to 3 per microliter or cubic millimeter. So, paano natin ko-convert ng SI? 3 plus 6. So, multiply natin. Kailangan ang SI unit must be 10 raised to 9 per liter. So, gets nyo na ba yan? No? Hindi talaga siya multiplication in terms of exponents ha. Pag exponent, add yan. Okay, reference ranges naman. So, in RBC, okay, kung i-observe lang natin, no, pinakamarami sa adult males dahil dun sa effect of muscle mass and testosterone. Okay? So, halos magka-value ang adult females and children. Sa WBC naman, pinakamarami sa mga bata, lalong-lalo na sa mga newborns, no? And then sa adult female, actually dalawa ang normal value. Ay depende kung pregnant yung patient. Pag pregnant, mas mataas yung cut-off natin sa kanila dahil meron tayong physiologic leukocytosis pagdating sa pregnant women. Okay? Okay. In interpretation naman tayo, erythrocytosis is defined as increased RBC and may be seen in number 1, hemoconcentration. Ang hemoconcentration may be due to dehydration and burns. Kapag nababawasan yung fluid part of the blood as compared to your cells, no? Mas marami ngayon ang cells as compared to your plasma. Polycythemia vera, overview lang, no? This is the abnormal proliferation of your RBC. No? May abnormal process of erythropoiesis. In cyanosis naman, no? Bagsak ang levels of your oxygen maybe due to lung disease or heart disease. So, kailangan mag-compensate ni bone marrow, no? To bring the oxygen up to the normal level. Decreased RBC is termed as erythropenia. Overview lang ito, no? Babalikan naman natin to lahat next semester. Okay, most common cause of your decreased RBC is the anemia. May physiologic RBC loss in pregnancy and old age. Leukocytosis is defined as increased WBC, commonly seen in infections, pregnancy, na-discuss natin kanina, may physiologic increase of or physiologic leukocytosis, and severe pain. Kaya hindi natin masyadong sinasaktan ang pasyente kapag venipuncture because it can cause falsely elevated WBC. Leukopenia naman, may mga infections, no, na nagpapababa ng WBC. Hindi lahat, no, na kayang mag-cause ng high WBC. Ano yung mga exceptions na yun? Number 1, typhoid fever, which is caused by your Salmonella typhi, tuberculosis, measles, and influenza. And in other cases, leukemia. Bakit dun sa ating bone marrow aspirate, madami ang myeloid cells? So, ibig sabihin, dapat may leukocytosis sa leukemia. Not very often. Kasi, ang mga myeloid cells in leukemia, madami nga, pero non-functional. No? Hindi nako-convert into mature cells. Let's proceed with WBC differential count. So, lagi natin tatandaan, no, sino ang pinakamarami and sino ang pinakakonti. Ang ating right sequence dyan is neutrophil, lymphocyte, monocyte, eosinophil, and basophil. So, tandaan natin yung mnemonics na never let monkey eat banana. Pero not at all times, no? Depende yan sa age. Kapag adult, doon predominant ang neutrophil. Kapag sa mga bata who are less than 4 years old, lymphocyte ang mas madami sa kanila. Okay? Routinely, no, ginagawa natin is 100 cell differential. Magka-count kayo ng 100 WBC and you differentiate each type according to the type, no? And then, hindi naman laging ganito, no? Kapag ang WBC ay less than 1 times 10 to raised to 9 per liter, ang kakount mo lang is 50. Okay? Kasi wala kang makikita sa PBS mo nito, no? Mahihirapan ka. So, okay lang na 50 and then i-multiply mo na lang ng 2. Okay? 200 cells naman if merong mamimit na isa sa mga criteria nito, no? Number 1, more lymphocytes than neutrophils except in children. Kapag yung adult patient mo, no, mas maraming lymphocytes, magto 200 cells ka. Okay? Tandaan natin ha, children, normal ang lymphocyte predominance. So kapag adult lang ang patient, doon mo gagawin ito. Or, kapag i-memorize lang natin itong mga magic numbers, no? 10% eosinophil, 11% monocyte, and 2% basophil. Pwede ka nang mag 200 cell differential. Okay? So, there are two presentation of your WBC count. Pwede mo i-present as relative or absolute. Ang relative, ito yung usual nyo nakikita sa inyong mga laboratory results which is expressed in percentages. Okay? Pero the more accurate form is your absolute WBC. So, paano yan pinapresent? It is expressed in number of cells times 10 raised to 9 per liter of blood. So, ang formula natin dyan, kailangan mo munang kuhain si relative WBC plus yung total WBC mo. Okay? Okay, let's proceed with the example, no, situation. Ang given na information, the relative WBC count of neutrophil is 50%. Total WBC is 5 times 10 raised to 9 per liter. So, paano mo yung i-compute? I-convert mo yung percent form into whole number, multiply by 5, okay? And then, makuha mo na siya. 2.5 times 10 raised to 9 per liter ang absolute WBC count of neutrophil based on the given information. Okay. Sa PBS picture din naman, no, pwede tayo mag-add din ng additional information such as shift to the left and shift to the right. Ano ang meron sa shift to the left? Okay? Ang ibig lang sabihin nito, no, mas marami yung mga immature granulocytic cells na pwedeng mangyari in leukemia and bacterial infection. Lalo na kung ma-appreciate mo yung madaming band cells. Okay? Shift to the right naman, kapag madaming hyper-segmented neutrophils which is commonly seen in megaloblastic anemia. Remember the mnemonics ho-ho, di ba? Yung H doon is hyper-segmented neutrophils. Dito naman tayo sa mga terminologies natin on how to interpret your WBC differential. Okay. Neutrophilia means increased neutrophils. So, most commonly seen in almost all bacterial infection. Neutropenia, decreased neutrophils, can be seen in typhoid fever, influenza, and measles. Lymphocytosis naman may happen in viral infection. No? Ibig sabihin, increased lymphocytes. Lymphopenia, decreased lymphocytes, which may caused by excess irradiation because radiation may destroy or lessen the lifespan of lymphocytes. Monocytosis can happen in tuberculosis and malaria. Eosinophilia naman sa asthma, hypersensitivity and parasitism, no? And basophilia, again, sa mga hypersensitivity reactions. Okay, proceed tayo with analysis of hemoglobin. Balikan natin no, yung ating conversion factors and the reference ranges. The traditional unit for hemoglobin is grams per deciliter. Ang SI unit, grams per liter. So, paano natin i-convert yan? I-multiply mo yung value mo ng traditional by 10, okay, to proceed with SI unit. Okay? Halimbawa dito, no? Tingnan muna natin yung mga values ng ating age groups. Pinakamarami pa rin ang ating adult males due to muscle mass and testosterone. Okay? Ito ay naka-traditional unit, right? Paano mo yan i-convert into SI? So, halimbawa dito sa male, multiply by 10. So, ang SI unit nitong adult males ay 140 to 180 grams per deciliter. Okay? So, let's proceed with the analytic methods of your hemoglobin determination. Number 1, the oldest type is your acid hematine methods, which ang most common reagent is your hydrochloric acid. And, gagamit ka ng comparator block na brands maybe either Sally Hellige comparator block or Sally Adams comparator block. No? Ang principle nito is that yung acid will burst the RBC, releasing all the hemoglobin content. The darker the color, mas maraming content ng hemoglobin. So, i-compare mo yung value dun sa comparator block. The next test is actually not solely for the hemoglobin level, no? This is called your alkali denaturation test or AP test, no? The theory behind this test is that all RBC will lyse in alkaline environment, no? Pero may exception. Yung mga newborn RBC can resist the alkaline fluids, no? It can survive. So, para saan tong test ngayon ito, no? it serves as a screening test, no, for the presence of your hemoglobin F. If ever, no, gusto mo pa ng further studies, pwede kang mag-proceed with Clay-Hauer-Betke test. Ito naman, no, ginagamit siya in cases of RH incompatibility between the mother and the baby. So, paano nangyayari RH incompatibility? Si mother ay RH negative, si baby ay RH positive. Okay? Pag nag-meet itong dalawang antigen or antibody, magkakaroon ng hemolytic disease of the newborn pagdating kay baby. Lalong-lalo na sa second anak, no? Kasi sa first na baby, wala pa na-produce na antibody si mother against the baby. Sa second, sa second birth pa lang. Okay? So, kino-compute ito, no? Iko-compute mo yung na-expose na maternal blood sa baby. And kung ilan yung na-expose na maternal blood, yun ang ibibigay mong ROGAM or yung ating medicine to neutralize the antibodies from the mother. Okay, the next hemoglobin determination is the earliest quantitative, no? Kaya niyang magbigay ng accurate level as in contrast with the early two analysis, no? Comparison lang by colors or colorimetric. Ito quantitative na tayo. Okay, this is the gold standard, no, which is being used in the machines, no. Ito yung principle din behind the ating mga automated machines. All forms of hemoglobin can be detected by cyan-met hemoglobin method, except the sulf-hemoglobin because it can resist the lysis of the Drabkin's reagent. Ano bang ginagawa nitong Drabkin's reagent? So first, no, i-expose mo yung hemoglobin to potassium ferricyanide, forming your met hemoglobin. And then met hemoglobin will be mixed with potassium cyanide, forming the end product called cyan-met hemoglobin na pwede mo nang sukatin through spectrophotometer. Si sulf hemoglobin resists the reaction of your Drabkin's reagent. So, hindi siya magandang gamitin if nagsususpect ka ng sulf hemoglobinemia sa pasyente. Okay? So, meron na tayong modified Drabkin's reagent, no, to intensify or para ma-improve yung technique. So, ang ating ina-add dito sa modified Drabkin's reagent, yung number 3 and 4. So, non-ionic detergent, ito naman, it improves the lysis of RBC. Therefore, mas mabilis yung release of hemoglobin. Okay? And other advantage nito, it decreases the turbidity, okay, caused by the proteins present in the plasma. So, in turbidity kasi will disturb the determination by spectrophotometer. And lastly, your dihydrogen potassium phosphate will allow the test to be read after 3 minutes only. Kasi normally or previously, mas matagal to, no? More than 25 minutes, supposedly. Itong reagent, mapapabilis niya yung process of reaction ng 3 minutes lang. Okay, the color of cyan-met hemoglobin must be measured at 540 nanometers spectrophotometrically. Okay? So, ang principle behind that the intensity of the color of cyan-met hemoglobin is directly proportional to the concentration of the hemoglobin of the patient. So, meron tayong further improvement pa. Dahil nga cyanide is a toxic waste, no? In automated method, pinapalitan ng cyanide ng SLS or the sodium lauryl sulfate so that wala kang may tatapon na toxic waste. Meron din naman ginagamit din na handheld system na pwede mong sukatin ang hemoglobin bedside, no? Katabi mo lang yung pasyente, mababasa mo na yung hemoglobin levels niya. Okay? In this machine called HemoQ, kino-convert naman ang hemoglobin instead of cyan-methemoglobin magiging azide hemoglobin. And spectrophotometer ulit, no? At 500 nanometer and 880 nanometer naman. Okay. Another information na kailangan natin alamin, no? Itong mga sources of error for the cyan-methemoglobin method since it is the gold standard for the quantitative analysis of your hemoglobin. So, unahin natin, no? High WBC and high platelet count may hinder the analysis of your hemoglobin. Okay? So, makaka-disturb siya with the lysis of your RBC. Lipemia and abnormal globulins may present as turbidity, no? So, kailangan din ma-address natin yan. Okay? And your HBS and HBC, itong mga types of hemoglobin can resist the lysis. So, hindi mo rin sila nababasa under this method. So, ito yung mga correction natin dyan. Pero most common sa ating board exam, no? Ito yung mga dalas na tinatanong. Ano yung mga sources of error? So, ito lang pwede nyo nang pwede nyo lang i-memorize. Number 4. So, proceed tayo sa mga electrophoresis. No? Meron tayong tinatawag na alkaline and acidic or the citrate electrophoresis. Sa alkaline electrophoresis or also known as cellulose acetate, dahil ito yung most common media na ginagamit for alkaline electrophoresis. Ang pH natin dyan must be alkaline from the name itself. Ano ang pH natin dyan? Should be 8.6. Okay? So, ang travel nito, no, from your from your positive charge going to the anode side, no, the negative electrode. Okay? So, ang travel nito, papunta from cathode to anode. Okay? So, ano yung mga pinakamabibilis and pinakamababagal na mag-travel na hemoglobin? Unahin natin yung mga normal hemoglobins. Ang pinakamabilis sa kanila is the adult or the major adult hemoglobin A1. Next is the fetal hemoglobin and lastly your A2. Sa abnormal naman, no, ang pinakamabilis is the HBH and HBI. Ang HBH, recall lang natin, no, it has the 3 globin chain deletion. Okay, mas mabilis pa siya sa mga normal. And then next na mabilis is yung Bart's hemoglobin. As compared with your HBH na 3 globin chain deletion, dito naman 4. And nako-convert silang lahat into gamma globin chain. So, ang composition ng Bart's 4 gamma globin chain. Okay? And then next groups, SDG, hemoglobin SDG, and hemoglobin CEO, which is yung slowest pagdating kay alkaline electrophoresis. Okay? Kapag naka-observe ka ng abnormal hemoglobin during alkaline electrophoresis, you have to proceed to the next step, which is the citrate agar electrophoresis. Ito yung ating method of choice for the hemoglobin or the globin problems, no? Yung mga hemoglobinopathies natin. Screening method lang yung previous natin. Ano ang difference between your alkaline and your citrate agar electrophoresis? Sa alkaline environment. Citrate agar, acidic environment dapat, no? at 6.2 pH. So, ang travel niyan pabaligtad, okay? From your anode going to cathode. So, sa mga normal hemoglobins, no, mabilis ngayon yung ating major and minor adult hemoglobin. Last naman si fetal hemoglobin. Sa mga abnormal, no, pinakamabilis si C, next si O, and then S, and then the groups D, G, E. So, bakit to kinonsider as the method of choice? Okay? Kasi napaghiwalay nito yung ating mga magkakasama kanina, right? Magkakasama si S, D, and G, C, and E, and O sa alkaline electrophoresis. Pagdating kay citrate, kaya na niyang paghiwalayin. So, ito yung ating principle of the test. No? Kaya siya naging method of choice. Kaya niyang paghiwa-hiwalayin yung mga abnormal hemoglobins. Ano yung ating mnemonics pagdating dito sa citrate-agar electrophoresis? FASOK. Okay? Ang pinakahuli, pinakamabagal, F. Sunod si adult and minor hemoglobin. Hemoglobin S, O, and pinakamabilis is hemoglobin C. So, tandaan din mnemonics na FASOK. Okay? Dito naman tayo sa hematocrit determination. Umpisahan natin with conversion factor. The additional unit is in percentage form, and you have to take note that the SI unit which is less natin ginagamit is liter per liter of blood. So, paano natin ko-convert? Gawin lang natin whole number yung traditional unit by dividing it by 100 to get the SI number or equivalent of the hematocrit. For the reference range, no, pinakamarami sa newborn dahil may halo pa na maternal blood, no? And yung mga young cells hindi pa masyadong nade-degrade by the spleen dahil hindi pa masyadong well-formed ang spleen. Okay? In comparison of adult female and adult males, syempre mas marami pa rin si adult male due to the number of levels of testosterone and muscle mass. Now, we have rule of 3. No? Pwede natin i-compute readily ang hematocrit by using hemoglobin and RBC count without directly measuring for your hematocrit. This pero ang disclaimer, this can only be applied to normocytic and normochromic cells. In automated methods, no, sa mga machines natin, hindi rin siya directly quantify, no? Kino-compute lang din siya by using MCV, multiply it by the RBC count. Okay? Balikan natin si rule of 3. So, una, kuhain mo muna si RBC. Okay? Pagdating kay RBC, multiply mo ng 3, doon mo makuha ang hemoglobin level. After that, multiply ka ulit ng 3 sa hemoglobin, doon mo na makukuha si hematocrit. Okay? Take note lang natin sa automated method ha, iba na ang formula. MCV multiply by RBC counts. Now, ano ba talaga yung hematocrit? No? After centrifugation of your blood, ito ang litaw ng layers of your blood. So, first layer, no, hindi madalas present is the fatty layer. Kapag lang meron kang or hindi ka nakapag-fasting ng maayos or kumain ng fatty food, present usually ito. And ito yung nauuna sa after centrifugation. Second layer is the plasma, which contains water, proteins, and other hormones and nutrients. And then third layer is the buffy coat. Anong meron kay buffy coat? Aside from your white blood cells and platelets, meron din itong nucleated RBCs. Okay? So, yung mga wala namang nucleus, dun sila sa ilalim. No? Ito ngayon yung packed red cells natin or tinatawag nating hematocrit. Now, tuloy tayo with the analytic determination of hematocrit. First technique to be discussed is the macro-hematocrit tube. From the name itself, macro means big. So, kailangan natin ng large amount of blood dito sa technique na to. And we usually use Winthrop tube or in other books, Winthrop and Landsberg tube. Ano ang meron dito sa apparatus na to? So, papansin natin, no, iba yung marking sa left and right. Sa left side, ang marking start with 0, papunta sa 10 sa bottom, and then sa right side, 10 to 0. In other brands, may mapapansin tayong color-coded yung mga yan. Sa left side, kulay red yan. Sa right side, kulay white. So, para hindi tayo malito, magka-rhyme lang si right and white. Okay? And ano ang ginagamit natin for macro-hematocrit technique? Yung right side. Okay? Yung left side, ginagamit siya for ESR to be discussed later. What is the anticoagulant of choice for this technique? Any anticoagulant which contains oxalate. For this matter, no, Winthrop tube uses double oxalate. Sodium oxalate naman for Van Allen, Hayden, and Sanford-Margath method. With exception of Brace method. Sa Brace method, heparin ang ginagamit. Okay? Balikan natin si Winthrop tube. Ano yung mga characteristics or features ng Winthrop tube? Ang length niya is 11.5 centimeters. Pero in other books, may mabasa kayo na 11 centimeters lang. So, okay lang yan, no? Meron tayong nilalarong range from 11 to 11.5. Yung bore naman natin or yung opening of the apparatus measures 3 mm in diameter. So, paano ginagawa itong technique na to? We will centrifuge the blood specimen for 30 minutes with the centrifugal force of 2,000 to 3,000 gravity force. Okay. Micro naman tayo. Micro-hematocrit tube method makes use of lesser amount of blood. Kapag mas konti ang blood, ibig sabihin mas mabilis siyang nasi-centrifuge. So, lesser time consume and better yung packing of cells kasi maliit lang yung daluyan ng blood specimen. Other name for the micro-hematocrit tube is Adams method. Okay? And the anticoagulant of choice for this method is heparin. In contrast with the macro, oxalate containing anticoagulant dapat. So, dito tayo sa apparatus na to. Color-coded din itong mga capillary tube natin. Meron tayong red, meron tayong white. Okay? Ang may heparin is yung red. Okay? Yung walang anticoagulant, no, is yung blue. Hindi madalas ginagamit to kasi naninigas agad yung blood, so mahirap i-centrifuge. So, mas better kung heparinized blood ang gagamitin. Okay, ano yung mga features naman nito? Hinighlight ko to kasi natanong to nung time ko nung nag-boards ako. I don't think na nakuha ko to. So anyway, no, may question bank kasi sa board exam. So talagang na-recycle yung tanong. So for now, memorize na natin, no? What is the length of the capillary tube? 7 to 7.5 centimeters. Pero kung in millimeter yung tanong, 70 to 75 millimeter. Okay? Pero naalala ko nung time ko, in centimeter yung tanong. Okay? Feeling ko mali ako doon. Pero anyways, let's move on. Bore diameter naman, mas maliit. Siyempre, 1 millimeter. And gaano ba karami ang nakukuha niya or nako-collect niyang blood? At least 0.05 ml of blood. Kaya tinawag natin siya micro-hematocrits kasi sobrang konti lang ng kailangan na dugo. Gaano karami ang dapat natin i-fulfill? Dapat hindi sosobra, no? Hindi natin i-fulfill lahat. At least 5 centimeter of blood yung kailangan natin ma-fulfill. So, dapat may libreng 2 to 2.5 centimeter. Okay? And then, for this technique, we will centrifuge the blood specimen for just 5 minutes with centrifugal force of 10,000 to 15,000. Okay, RBC indices naman tayo. The three most common RBC indices are MCV, MCH, and MCHC. Your MCV stands for mean corpuscular volume. MCH is mean corpuscular hemoglobin. MCHC, dagdagan lang natin, mean corpuscular hemoglobin concentration. So, anong clinical significance ng bawat isa? MCV, it is the measure of the RBC volume or the average size of the RBC. Isa rin ito sa mga index ng anisocytosis pero mas ginagamit si RDW over your MCV. MCH naman, the average hemoglobin per blood specimen, no? Hindi ito madalas ginagamit for classifying anemia, pero sinasama pa rin siya as part of your RBC indices. MCHC naman, it is an index of anisochromia. Ano ibig sabihin ng anisochromia? Yung color of the RBC under microscope, kung iba-iba sila. Because the color will indicate the relative hemoglobin content per cell. Okay? So, ano ulit ang MCV? It is used as an index for anisocytosis, MCHC for anisochromia. Okay. So, for the interpretation, we have, for MCV, meron tayong normocytic, macrocytic, microcytic. Sa MCHC, hyperchromic, hypochromic, and pag normal value, normochromic. Hindi madalas ginagamit si MCH for the interpretation. Okay? Overview lang of the anemia classified under each group. Kapag macrocytic anemia, madalas dyan yung mga megaloblastic anemia, big cells, no, yung involved dito. Microcytic, mga maliliit na cells such as yung ating ATIS group. Ano yung ATIS group? It stands for ACI, thalassemia, IDA, and sideroblastic anemia. And this belongs to microcytic type of anemia. Hyperchromic anemia naman, dito belong ang spherocytosis. Okay? Hypochromic, ATIS group ulit ito. Next parameter is reticulocyte count. So, reticulocyte count, this is the perfect index of your erythropoiesis. No? It will check the activity of your bone marrow. No? Either meron tayong problem sa bone marrow or meron tayong problem dun sa RBC lifespan. Other use of reticulocyte count is to monitor for iron therapy, lalong-lalo na sa mga merong IDA. Ang mga IDA patients natin, no, merong matagal ang gamutan dyan. And if ever matagal ang iron supplementation, nagkakaroon din sila ng iron overload, which is very fatal, lalo na sa mga batang patients. Kailangan mo mag-monitor every now and then using reticulocyte count. Okay. Increased reticulocyte count might mean there is an ongoing hemolysis. Okay. And decreased results might mean bone marrow problem or mababang levels of your erythropoietin. Okay. So, after, for the determination of counts, no, kailangan alam mo din kung ano bang itsura ng reticulocyte under microscope. So, based sa books, ano ang description niya? Non-nucleated, walang nucleus, pero merong 2 or more than 2 blue-stained granulofilaments. Itong granulofilaments are hair-like structure na naiwan na parts of the nucleus. These are your reticulum or the RNA. And it is only visible by supravital staining. May ibang instances, halimbawa sa severe hemolysis, no, nagko-compensate yung bone marrow mo to produce a lot of reticulocyte to compensate of the losses. So, hindi nasusundan yung rule of maturation na dapat paliit ng paliit yung blood cells. Minsan na-maintain nila yung big size nila, kaya ang tawag sa kanila macro-reticulocyte or stress reticulocytes. Okay, sa reference range naman tayo. Sa mga adults, 0.5 to 1.5 ang makikita in the bloodstream. Bakit meron tayong immature cells sa ating bloodstream? Di ba reticulocyte is still immature? Okay, ang lifespan kasi ng reticulocyte, ganito yan. It will stay in the bone marrow of an average of 2.5 days. Lalabas na siya after that, and sa bloodstream naman, magsistay siya as reticulocyte for just 1 day before developing into a mature RBC. Okay? Sa newborns, mas mataas ang reference range natin, 2 to 6%. No? Mas mabilis yung turnover ng reticulocyte from the bone marrow going to the bloodstream to compensate yun nga yung ating fetal hemoglobin dahil mababa yung nadadala nilang oxygen. Let's proceed with the supravital staining technique. As mentioned earlier, this is the only staining technique that can stain the granulofilaments of your reticulocyte. So we have two reagents that can be used for this technique. We have NMB or the new methylene blue, BCB or brilliant crescent blue. So anong difference and similarities ng dalawa? Both of them contain sodium chloride which maintains the isotonic environment of the blood specimen so that walang nag-shrink, walang nagsiswell or nagbe-burst. Okay, na-maintain lahat ng RBC size. In contrast with the anticoagulants, magkaiba sila. Yung methylene blue contains your sodium oxalate, brilliant crescent blue, sodium citrate. So, tandaan lang natin yung C ng cresyl citrate, C din sa citrate. Okay? Para hindi kayo malito kahit paano. And sino ang mas preferred over the other? Si NMB ang most preferred out of all, out of the two staining technique. Kasi ito yung mas readily available for the staining of reticulocytes. Okay. How about sa counting naman, no? Kaya mo identify, pero paano ba mag-count? So, we make use of calibrated mirror disc. And anong itsura nun? Nilalagay yon usually dun sa ating eyepiece of the microscope, no? So, ang makikita mo, ganyan. Okay? Meron tayong dalawang square. Meron tayong smaller square and bigger square. Sa bigger square yung square A, smaller square yung square B. Saan kayo magbibilang ngayon ng reticulocyte and RBCs? Sa reticulocytes, yung sa square A. Okay? Sa square B naman, yung ating RBCs. And in actuality, no, gaano ba kalaki itong area ng B? Gaano siya kaliit as compared to your square A? Based sa books, square B is just 1/9 of the area of your square A. So, paano natin gagamitin yung information na yan? So, gagamitin natin siya sa ating formula. So, reticulocyte counts na nabilang mo sa square A over yung mga nabilang mong RBCs in the square B multiply by 9, okay? And in percentage form, so multiply natin sila by 100. Okay. While in routine light microscope, iba ang ating method of counting. Okay? So first, we count an approximate 1,000 RBCs under OIO. So, in practice, halos 10 fields yung mga yan. So, assuming merong 100 RBCs per field. Okay? So, out of the 10 fields, no, kung ilan ang nabilang mong retics over the RBC count na dun sa ibibigay sa na data, okay? Multiply by 1,000, okay? So, kapag in percentage form, multiply mo yung answer mo by 100. So, that is the reticulocyte count based on light microscope method. And hindi natatapos dyan yung ating computation. Meron tayong mga next formulas na susundin. Yung ARC or the absolute reticulocyte count, CRC, corrected reticulocyte count, and yung mamaya reticulocyte production index or RPI. So discuss muna natin yung ARC. Ano bang ibig sabihin nito? Ilan daw yung reticulocyte per liter of blood. So, yun yung absolute reticulocyte count. So, ano ang mga information na kukunin mo? Yung na-compute mo retics in percentage form, multiply mo sa given na RBC count over 100, multiply by 1,000. Okay? Kasi 1 liter, no? 1,000 milliliters. Okay? So, ito yung formula for ARC. Next, bakit mo naman gagawin tong CRC or corrected reticulocyte count? Ito, ginagawa to usually, lalong-lalo na sa mga anemic patient, no? Kasi iba nga naman yung bilang ng mga RBC counts. So, magde-depend kasi doon yung ating reticulocyte. So, ang other name for this type of formula is reticulocyte index. Huwag kayong magpapalito mamaya, no? Mamaya meron tayong RPI, reticulocyte production index. Magkaiba to dito sa ating CRC. Tingnan naman natin yung formula. So, kunin natin yung info about percentage retics. Multiply mo doon sa patient's hematocrit in whole number or in SI unit. Okay? Over 0.45. Bakit 0.45? Kasi ito yung average normal hematocrit. Okay? So, constant itong 0.45. Okay, let's proceed with the RPI or reticulocyte production index or in other books, shift correction. So, from the name itself, di ba medyo nakakalito doon sa previous na CRC? CRC is corrected reticulocyte count or reticulocyte index. So, huwag tayo magpapalito doon sa dalawang term na yan. Okay? Ano ang mas better gamitin in terms sa mga anemic patient? Mas accurate itong RPI dahil we take into consideration the maturation time of the reticulocyte in the blood stream. Okay? Normally, no, kung ang patient mo ay merong normal hematocrit, which falls from 40 to 45, a normal maturation time of the reticulocyte in the bloodstream is 1 day. Okay? Pataas ng pataas kapag pababa ng pababa ang hematocrit. So, kailangan i-memorize din natin to. Okay? Divisible by, ginawa natin 10, no? 40 to 45, 1. 35 to 39, 1.5. 25 to 34, 2 days. 15 to 24, 2.5. And less than 15%, 3. Okay? Sana, ang gagamitin sa boards is yung from products. This is from products. Actually, nagkakaiba-iba, no, per book. Ang importante lang dyan, no, alam natin na yung normal na hematocrit is equal to 1 day maturation time. Okay. For the interpretation, no? After mo dinivide ang CRC by maturation time, ang adequate response of bone marrow to anemia is dapat more than 3. Okay? Ano ibig sabihin nun? Kapag tama yung management mo or yung therapy mo, ibig sabihin, mas okay yung production ng reticulocyte, nakakapag-compensate kumbaga yung bone marrow dun sa RBC loss mo. Kapag less than 2, ibig sabihin kulang yung activity ng bone marrow. Okay? Either may problema tayo directly from the bone marrow or directly from the process of electrophoresis, such as in megaloblastic anemia. Eosinophil count naman tayo. Hindi ito madalas ginagamit for routine hematologic testing. No? May kakaiba yung ating gamit pagdating sa eosinophil count. So, explore natin yan mamaya. We have to take into consideration ng eosinophil count varies all throughout the day. Okay? In physiologic changes, no, meron tayong physiologic increase in eosinophil, lalo-lalo na sa gabi. Mababa lang yan pagdating sa late morning or tinatawag 8 a.m. to 10 a.m. Pathologic naman kapag merong associated disorder, increased in allergy, parasitism, and leukemia, specifically your M4EO. Ano ba yung M4EO? M4EO, based on the FAB classification of leukemia, ang ibig sabihin nun is acute myelomonocytic leukemia with eosinophilia. Okay? Other pathologic condition associated with decreased eosinophil count are your Cushing's disease or tinatawag natin hyperadrenalism, shock. Ano meron siya shock? Mataas ang level of your cortisol, no, to compensate for the losses of the bodily fluids. And then, after ECTH therapy din, lalo-lalo sa mga pasyenteng bagsak ang cortisol, nag-therapy tayo ng ECTH, and right after that, nag-react yung ating eosinophil count, bumabagsak na right away. Okay. For the hemocytometry of your eosinophils, kakaiba yung ating gagamitin na reagents. The diluting fluid may contain the following. Number 1, yung floxin. Floxin will stain the granules of your eosinophil as red in color. Sodium carbonate naman, ilalyze niya o i-burst niya lahat ng WBC except the eosinophil. So, better, no? Matitira lang si eosinophil to count. And then, para naman sa other cells, no, RBC lysis, yung ating propylene glycol. And para hindi magdikit-dikit yung ating mga eosinophil, we make use of heparin. Sa counting chambers naman, gagamit pa rin ba tayo ng improved Neubauer? Hindi na. Kasi, konti lang yung ating specimen na ginagamit for eosinophil count, hindi na siya appropriate for the counting chamber use in Neubauer. Mas appropriate yung mga mas maliliit, yung Fuchs, Rosenthal, and Spears-Levy. So based dun sa ating variations, no, ginagamit nga ang eosinophil count in terms of the assessment of your adrenal cortex. Okay? Kasi naapektuhan yung hormones natin yung ating eosinophil count. So, meron tayong test na tinatawag natin Thorne's test. And in this technique, we make use of 2 samples. Ang unang sample mo is you have to collect a fasting specimen. And then sa fasting specimen na yon, kakount mo yung eosinophils. So this is your eosinophil count 1. And then the second specimen is that after 4 hours after your ACTH therapy. After that, magka-count ka ulit and this will be your eosinophil count 2. Normally, kung okay yung adrenal cortex mo, dapat mas malaki yung number of your eosinophil count 1 as compared to your eosinophil count 2. Okay? Kasi it will ACTH drug will decrease your eosinophil count. So, dapat mas mataas si 1 over the 2. In hypoadrenalism, parehas yung 1 and 2. Okay? Kasi, yung ating adrenal cortex will, will decrease the hormones of adrenal cortex will decrease the eosinophil count kahit walang ACTH medication. So, bagsak din si 1, bagsak din yung 2. Halos pantay. So, halos equal sila in numbers. So, let's proceed with the next parameter, ESR or erythrocyte sedimentation rate. This is an obsolete test, okay? Kasi hindi siya specific indicator of any disease. Kahit anong inflammation or tissue injury, kayang mag-increase yung ESR, okay? Except what type of conditions. Kakik siya, or the loss of body mass, congestive heart failure, and newborns can cause decreased ESR. So, ito lang yung type of condition na nagpapadecrease ng ESR. And this has a common denominator which is low levels of proteins. Remember, proteins ang nagpapataas ng ESR natin. So, ano ba yung mga stages of sedimentation of RBC? We have the first stage which is called lag phase. Dito nagkakaroon ng initial rouleau formation. No? It takes about 10 minutes. The next phase, mas matagal, 40 minutes or tinatawag natin decantation phase. Dito, mas rapid na yung settling of the RBC kasi mas nagko-connect na yung kanilang electrical properties of the membrane. And then, lastly, the final settling, 10 minutes ulit, final sedimentation of RBC na. So, overall, para ma-achieve mo yung accurate sedimentation rate, kailangan matapos mo yung buong 1 hour. Then, let's proceed with the factors affecting your ESR. So, aside from the na-mention kong mga conditions, no? Diba sabi natin, halos lahat ng conditions will increase ESR except kakiksya, congestive heart failure, and newborn patients. Dito naman tayo, type of cell. As a rule, ESR is directly proportional to the weight of the cells. Okay? Mas mabigat, mas mataas ang ESR. So, ano yung mga mabibigat na cells? Number 1, macrocyte due to enlarged cell. RBC inclusions, no, may mga laman na mga abnormal pigmentation or inclusions na nagpapabigat sa cell. It will increase the ESR. Ano naman yung mga mayroong decreased ESR? Microcyte due to less or smaller size of the RBC. Poikilocyte. Bakit decrease dito? Kasi kakaiba yung shape. Hindi maganda yung pag-rouleau formation. Okay? Sa polycythemia naman, madami ang cells as compared to your proteins which may trigger rouleau formation. Kung wala kang mga proteins, konti lang yung mag-rouleau formation kahit na sobrang dami mong cells. Okay? Next naman, sa mga plasma content. Ang sabi sa rule, ESR is inversely proportional to the plasma viscosity. More viscous ang ating plasma, lesser yung ating ESR. Okay? Sino yung mga nagpapa-viscous or sino yung nagko-contribute sa viscosity of the plasma. Unahin natin yung ating albumin. Okay? More albumin content, lesser yung ESR. Okay? Hindi maganda ang rule formation kapag mas viscous ang plasma. All other plasma proteins can increase ESR. So, ito yung mga hindi nagko-contribute for the plasma viscosity. Fibrinogen, alpha-2 globulin, and cholesterol. Okay. Technical factors naman. Outside of your blood specimen, sino yung mga nagpapa-affect sa ESR? Okay, directly proportional ang angle, temperature, diameter of tube, and vibration. Mas mataas yung tilting. Ano ba yung tilting? Yung hindi straighten up ng ating tube, mas mataas ang ESR. Okay? Kumbaga, 'di ba ang rule natin dapat naka-straighten up yung ating tube. If ever na nagkaroon ng angular or tilting, napapataas or naapektuhan yung ESR, increasing the rate of sedimentation. Temperature, more or higher the temperature, higher din ang ESR. The diameter of the tube, mas mataba ang hole or the bore of the tube, mas maganda ang sedimentation, mas mataas ang ESR. Vibration naman, mas nagba-vibrate ang surface, mas mataas ang ESR. Dito naman tayo sa indirectly proportional. Mas maraming EDTA level sa ating blood specimen, mas konti ang ESR kasi hindi maganda yung rule formation if ever mas madami yung ratio ng EDTA as compared to your blood. Delay testing naman, napabayaan mo, no? More than siguro 2 hours, nadidislodge yung rule formation, pumapangit yung, or hindi nagiging accurate yung ESR natin. Okay? So, bumabagsak as you delay the testing. Presence of the bubbles. Okay? Bubbling. The more bubbles, the lesser your ESR. Sige, apply naman natin dito sa ating situation. So, more tilted ang tube, again, directly proportional ang angle, so high ESR. More bubbles, ibig sabihin, indirectly proportional ang bubbling, so low ESR. Low temperature, directly proportional ang temperature, right? So, low ESR din. Vibrating surface, the more vibration, higher the ESR. So, high ESR yan. Okay, next. Situation naman tayo or application. So, madalas to tanungin sa board exam schools, I mean yung mga review centers, no? So, ito yung tamang answer for this situation. So, bibigyan tayo ng ganitong case. The ESR tube is placed directly on top of a small refrigerator. What are the possible effects? So, tatlo ang pwedeng explanation. Falsely low, if ever, no, malapit ang ESR tube dun sa pintuan ng refrigerator, which can release low temperature of air. So, low temperature, low ESR. Falsely high, pwede din, in cases na vibrating yung surface ng refrigerator. Di ba may mga ganong type of refrigerator, medyo intense yung vibration sa taas or dun sa machinery niya. And pwede rin na high temperature, lalo na kung ang ESR tube mo nasa malapit dun sa rear side of the refrigerator or malapit dun sa motor, dun sa likod. Okay, we have 3 methods of ESR determination. We have Westergren, modified Westergren, and Winthrop tube. So, anong difference ng tatlo? Dun sa gamit na anticoagulant. Westergren makes use of 3.8 sodium citrate. Ano ang difference nito dun sa ating normal na light blue citrated tube? Black ang vacutainer top and 1:4 ang ratio nito. And then sa modified Westergren, EDTA lang. Winthrop tube, again, double oxalate anticoagulant. Pagdating naman sa technique, no, mas matagal gawin si Westergren. You have to read it after 1 hour. Then, uulitin mo ang reading after 2 hours. Sa modified Westergren, after 1 hour lang din, as well as in Winthrop tube. And the most recommended type is the modified Westergren method. Okay. Compare natin yung dalawang apparatus, yung Westergren tube and Winthrop tube. In terms of length, obviously, mas mahaba yung ating Westergren, 30 centimeters. Si Winthrop tube, 11.5 or in other books, 11 centimeter. Sa bore size naman o yung butas ng ating apparatus, mas manipis yung Westergren, 2.5 mm and open on both ends ang Westergren tube. While in Winthrop tube, mas malaki at 3 mm pero open lang siya in one side of the Winthrop tube. So, sino mas mataas ang sensitivity in ESR? Si Westergren dahil mas manipis and mas mahaba yung ating apparatus, mas ma-determine natin yung right sedimentation process of the RBCs. Okay? Si Winthrop tube naman less sensitive dahil nga mas maliit and mas malaki yung bore size. Recall lang natin, no, 'di ba ang Winthrop tube, dalawa ang purpose niyan. Pwede siyang pang ESR and hematocrit. Sa left side, yung ESR, which has a red mark, and magsa-start ang markings from 0 to 10, while yung ating hematocrit sa right side with white marker, no? Umpisa yung markings from 10 going to 0 at the bottom. And then we will proceed with special diagnostic tests. Unahin natin yung mga tests for sickle cell anemia. The following tests are just for screening test lang. Okay? Kasi obsolete na to, hindi na to masyadong ginagawa in laboratory. So, unahin natin the hemoglobin solubility test or the sodium dithionate test. The principle of the test is that HbS or hemoglobin S has a low solubility when combined with the following reagents. Sodium hydrosulfite or the dithionite, which is a reducing agent. It converts your ferrous iron to ferric iron. And saponin, which dissolves the RBC membrane, releasing the hemoglobin. Normally, no, yung ating mga normal hemoglobin, magkakaroon ng lysis, kumbaga. Okay? And they are not resistant with this type of reagents. Kapag ang RBC mo contains hemoglobin S, resistant in lysis, therefore, turbid ang color of the specimen. So, ma-appreciate natin sila dito. Halimbawa, ito, it contains the normal adult hemoglobin, no? Complete lysis. So, you can see through and through yung paper do sa background. In contrast with the sickle cell, hemoglobin S, which is resistant to lysis. So, very turbid. Hindi mo makikita yung background paper. The next test for sickle cell anemia is the sodium metabisulfite. Parehas lang ito, no? Pero, hindi lysis ang ginagawa ng metabisulfite. It will cause sickling of the RBC. Lalong-lalo na, no, ang very vulnerable dyan kapag pangit yung ating hemoglobin content. in cases of sickle cell anemia. Normally, no, hindi magsisikling ang RBC in a normal patient. If ang RBC mo contains HbS, mas madali ang sickling, it will remove all oxygen from the hemoglobin, shrinking the RBC membrane. So, under microscope, i-observe mo yung iyong results, no? Meron tayong positive sickling dito. Ibig sabihin, possible na merong hemoglobin S content. Itong mga RBC na to. Okay? In other books, ang sabi nila, positive holly leaf cells. Ano yung holly leaf ba? So, nakakita ko ng picture sa internet na medyo hindi siya perfect crescent shape. Okay? So, may mga edges yung mga yan due to sodium metabisulfite. The next test that we will discuss is for PNH or paroxysmal nocturnal hemoglobinuria. As an overview lang, no, in this type of condition, the RBCs has a deficient levels of your CD55 or yung DAF. DAF means decay accelerating factor. Ang CD59, MIRL yan, or the membrane inhibitor of reactive lysis. Always remember 55-59 DAF MIRL. Back in my student days, ang mnemonics ko dito, ang 55, I mean yung DAF, mas nauuna sa, yung D sa DAF, mas nauuna sa M. Okay? So, alphabetically arrange lang natin. 55 yung D, 59 yung M. Mas nauna ang D sa M. Anyway, okay, dun tayo sa special test. We make use of two types of tests. Number 1, yung ating sugar water test or yung sucrose hemolysis test. And the other test is makes use of an acid, no? HAM test or acidified serum lysis test. In PNH, mas prone sa lysis ang mga RBC. Mga normal RBC resist the lysis from the sucrose and the acid. Okay, so ang more hemolysis, mas nagpo-point to PNH. Next test is the Schilling's test, and this is a special test to determine or to differentiate your vitamin B12 deficiency from pernicious anemia. Kasi magkaiba ang management ng dalawang ito. Okay? Ang pernicious anemia is an autoimmune disorder, while vitamin B12 deficiency may be caused by pernicious anemia or other causes pa. Okay? So, paano natin ginagawa yung Schilling's test? We have two stages. Okay? Sa part 1, magbigay ka muna ng vitamin B12 supplementation kay patient. If na-correct yung anemia niya, no, ibig sabihin, kulang lang talaga siya sa vitamin B12 or vitamin B12 deficiency. If hindi na-correct ang anemia, you proceed to next stage, which is the part 2. You give intrinsic factor. In this stage, kapag na-correct na yung ating anemia, ibig sabihin pernicious anemia ang final diagnosis. Because in pernicious anemia, meron kang antibodies targeting intrinsic factor. So, mababa ang levels mo na intrinsic factor in pernicious anemia. The next group of tests is to test for the membrane integrity. Okay? Ang most common na ginagamit in laboratory is osmotic fragility test. In this test, you expose your blood cells to a series of tube na may pataas ng pataas yung hypotonicity. Ano bang ginagawa ng hypotonic environment sa RBC mo? Okay? Kapag hypotonic environment, it will swell your RBC, and then kapag na-overswell na, puputok na sila, causing hemolysis. Okay? In this test, we make use of an heparinized blood specimen. Okay? To maintain para ma-prevent lang natin yung coagulation process. The reagent, sabi nga natin, hypotonic dapat ang reagent natin. So, it will range from 0.65 to 0.85% saline. Normally, ang RBC natin mag-hemolyze starting at 0.45 and then ang complete hemolysis is at 0.30% of saline. So, para ma-visualize natin, no? Compare natin hypotonic, iso, and hypertonic. Kapag hypotonic, una muna magsiswell and then mag-rupture. So, ito yung swelling of the RBC. Hindi mo na ma-appreciate yung kanyang donut shape, no? Yung central pallor niya. As compared to the hypertonic, shrink lang niya yung mga RBC. Okay? And then, therefore, yung ating plasma membrane may release after the shrinkage. So, much better to test for the membrane is through hypotonic solutions. Okay, to interpret the results of your osmotic fragility test, meron tayong tinatawag na shift to the left and shift to the right. Okay? So, paano natin i-visualize yan? Okay, di ba kanina, previous slide, ang sabi natin, the initial hemolysis of a normal RBC starts at 0.45%. The complete hemolysis will be at 0.30%. Kapag merong shift to the left, ibig sabihin, mas fragile or increased fragility, yung increased membrane fragility, which happens in hereditary spherocytosis. Agad pumuputok at 0.65, no? And then makukomplete at 0.45. Kaya tinawag natin shift to the left, nasa left side siya ng normal or expected results. Okay? Dito naman siya shift to the right. Okay, na-move dun sa right. Ibig sabihin, decrease yung RBC fragility, which happens in IDA, thalassemia, and sickle cell anemia. So, magsa-start pa lang hemolysis at 0.35 and even at higher hypotonicity, baka hindi nyo ma-appreciate pa yung complete hemolysis. So, balikan lang natin, no, to visualize the results. Sabi nga natin, the spherocytosis, madaling pumutok. Right? Kasi nga, ang spherocytosis, madaming increase ng MCHC, punong-puno ng hemoglobin sa loob. Okay? Once na pumasok, kahit konting water lang sa loob, pumuputok na agad. Kaya, meron tayong shift to the left or yun nga, increase ang RBC membrane fragility. In contrast with thalassemia, IDA, and sickle cell anemia, ito, target cell, most common sa mga thalassemia, okay? Walang laman yung mga yan, no? As kahit magpasok ng water dyan, hindi agad pumuputok yung RBC membrane kasi halos walang laman na hemoglobin yan sa loob. Next topic naman, the laboratory findings for the differentiation of hemolytic anemia. Diba dun sa ating first part of the hematology topics in SEM1, na-discuss natin yung difference between intravascular hemolysis and extravascular hemolysis. Recall lang natin, no, the other name for intravascular hemolysis is RBC fragmentation lysis. And yung extravascular naman is macrophage-mediated hemolysis. Okay. Generally, ang mapa-appreciate mo sa kanila, no, dahil lumalabas lahat ng hemoglobin out of the RBC due to hemolysis, yung ating mga byproducts na bilirubin and urobilinogen are both increased. Okay? Reticulocyte count then is increased to compensate for the RBC loss. Okay? And then, RBC, hematocrit, and hemoglobin are all low in levels dahil meron nga tayong ongoing anemia. So, the next part yung mga differentiating features natin. Haptoglobin is low in intravascular dahil yung mga free hemoglobin will attach to your haptoglobin. Hindi ginagamit ang haptoglobin sa extravascular catabolism. So, normal dito. Hemopexin levels naman is increased in intravascular pathway. Normal sa extravascular pathway. Bakit kaya? Naalala nyo yung hemopexin, haptoglobin, methylalbumin salvage system? Nangyayari lang yon in intravascular hemolysis. During that pathway, tumataas ang level ng hemopexin due to the conversion of your hemoglobin to hemopexin. Methemoglobin naman, present lang kay intravascular, absent kay extravascular. Methemoglobin is from the salvage system, kung maalala nyo sa first lecture natin. Free hemoglobin naman, present lang kay intravascular dahil sa loob mismo ng blood vessel, pumuputok ang RBC. Walang free hemoglobin sa extravascular dahil nangyayari lang ang lysis in the spleen. Sa peripheral blood picture naman, mas maraming schistocytes na ma-appreciate in the PBS. Sa intravascular, extravascular naman, mas maraming spherocytes. In urinalysis din, mas ma-appreciate mo yung dark urine due to hemoglobinuria sa intravascular catabolism. Extravascular catabolism, walang dark urine dahil walang hemoglobinuria. And that ends the hematology part of the SEM1.